Medical training heavily relies on standard protocols and strict pharmacological contraindications. These rules exist to prevent toxicity, manage antibiotic resistance, and keep patients safe from statistically common harms. But in the management of advanced infectious diseases, there are edge cases where rigidly adhering to these guardrails will kill your patient. We call this boundary the clinical exception threshold. It is the exact physiological moment a physician must intentionally violate core pharmacological rules to prevent a fatal outcome. To examine the mechanics of this threshold, we will deconstruct three specific clinical domains: systemic mycoses, tick-borne pathologies, and advanced HIV. Knowing the textbook standard of care is the baseline requirement of medicine. Knowing exactly when the underlying physiology demands that you abandon it is what separates competence from survival. This table compares endemic dimorphic fungi. Diagnostic suspicion is dictated by geography: histoplasmosis in the Ohio and Mississippi valleys, coccidioidomycosis in the arid Southwest. Pathological presentations also diverge. Coccidioidomycosis often presents with influenza-like symptoms. Histoplasmosis drives progressive pneumonitis and causes hepatosplenomegaly and pancytopenia. For a localized, mild to moderate fungal pneumonia, standard protocol applies. The patient can be managed in an outpatient setting using oral azoles, like itraconazole or fluconazole. But if the presentation involves severe pulmonary distress, disseminated lesions, or meningeal involvement, the standard guidelines no longer apply. Oral azole kinetics fail entirely. The slow tissue penetration of an oral azole allows the fungi to continue multiplying. You need a rapid fungicidal spike. This high-concentration tissue penetration physically disrupts the fungal cell membrane, halting further dissemination. Consider a patient from Missouri presenting with diffuse pulmonary infiltrates, profound pancytopenia, and palatal mucosal ulcerations. Standard empiric antibacterial protocols for community-acquired pneumonia will do nothing. You must reject them and immediately induce with intravenous liposomal amphotericin B. In systemic mycoses, pathological severity overrides administration convenience. Delaying fungicidal induction to wait for cultures guarantees rapid dissemination and patient death. Tick-borne pathogens present another distinct fork in clinical management, demanding precise identification of both the insect vector and the trajectory of the disease. This is Erythema migrans. The classic bullseye rash with partial central clearing characterizes early localized Lyme disease, transmitted by the Ixodes tick. Rocky Mountain spotted fever, transmitted by the Dermacenter tick, operates differently. The bacteria invade the endothelial lining of small blood vessels, causing severe vascular necrosis and extravasation of blood. This produces a petechial rash that begins on the wrists and ankles and rapidly spreads inward. Standard pharmacological stewardship strictly contraindicates tetracyclines, like doxycycline, in pregnant patients and children under 8 due to risks of hepatotoxicity and fetal bone discoloration. For early Lyme disease in these populations, the standard protocol is a switch to amoxicillin. Rocky Mountain spotted fever triggers an absolute exception. The disease drives rapid systemic vascular damage. Left untreated, the fatality rate reaches up to 25%. This extreme mortality risk mandates doxycycline as the absolute first-line agent for every patient, completely overriding standard tetracycline teratogenic warnings. If a 24-week pregnant patient returns from camping in North Carolina with a high fever and a petechial rash on her palms and soles, the diagnosis is clinical. Waiting for an indirect fluorescent antibody titer or defaulting to a beta-lactam like amoxicillin to avoid teragenic risk is a fatal stewardship trap. You prescribe doxycycline immediately. Advanced HIV complications introduce rigid spatial constraints. Survival depends on managing the physical volume limits of the pulmonary alveoli and the rigid intracranial vault. The frontline treatment for pneumocystis jirovecii pneumonia, or PCP, is high-dose trimethoprim sulfamethoxazole. Before administering the first dose of antibiotics, you must establish the patient's respiratory threshold, a room air arterial blood gas showing a PaO2 of 70 millimeters of mercury or lower, or an AA gradient of 35 or higher. If a patient meets these criteria, administering TMP-SMX rapidly lyses the fungal organisms. This massive cell death triggers an expansive inflammatory cytokine cascade that fills the already compromised alveolar spaces, destroying the patient's remaining respiratory capacity. To preemptively blunt this inflammatory cascade, adjunctive corticosteroids must be initiated simultaneously with or prior to the antimicrobial therapy. The management of cryptococcal meningitis introduces an inverse timing constraint. Standard induction therapy requires intravenous amphotericin B combined with flucytosine to clear the fungus from the central nervous system. The strict timing threshold here applies to antiretroviral therapy. You must strictly delay the initiation of ART during active CNS induction. Rebuilding the immune system too quickly triggers immune reconstitution inflammatory syndrome, or IRIS. The sudden influx of functioning CD4 cells aggressively attacks the residual fungal antigens in the brain. The resulting inflammatory swelling is physically trapped inside the rigid intracranial vault. The pressure increases until it causes fatal brain herniation. Surviving cryptococcal meningitis mandates a 2 to 6 week delay in antiretroviral therapy. In advanced HIV, identifying the correct antimicrobial is insufficient. The precise sequence and timing of your adjunctive therapies determine whether the patient lives or dies. Standard medical protocols exist to protect patients from statistically common harms, but adhering to them blindly in the presence of severe pathology creates disruptive stewardship traps. Initiating ANRT during active CNS cryptococcus induces fatal brain herniation. Withholding doxycycline in pregnant patients with Rocky Mountain spotted fever ensures vascular collapse. Attempting to manage severe disseminated mycoses with oral azoles allows unchecked fungal replication. Failing to order a baseline room air ABG in a hypoxic patient with PCP means missing the steroid eligibility threshold, allowing antimicrobial inflammation to obliterate the lungs. Consider a final presentation. An untreated, cachexic homeless patient arrives with a severe cough, focal neurological signs, and a CD4 count of 15. This specific intervention sequence must be exact. First, secure the airway and draw a baseline ABG to determine steroid eligibility. Second, immediately initiate empiric intravenous amphotericin B to cover the neurological deficits suggestive of CNS fungal involvement. Third, you strictly withhold antiretroviral therapy, despite the profoundly low CD4 count, to prevent an intracranial IRIS cascade. True medical expertise requires internalizing standard protocols, but saving a crashing patient requires understanding the exact physiological thresholds that demand you break them.